but we have a little business to take care of that's been delayed for about 4 or 5 years. If you go to my presidential address, you'll hear the history of the SCVS. And one of the reasons we're still here is because of a certain individual. It turns out that around the year 2000, the society realized that it had a $58,000 deficit and was going bankrupt and had to decide if they were going to dissolve this society. Many of you probably don't realize that. So Bill Brown, one of our past presidents, who was the treasurer at the time, spoke to a guy that used to be his local rep. That local rep in Michigan went on to become a pretty high-ranking individual in Gore, and he asked that individual, "Can you help us out?" And it turned out that Gore decided to donate $58,000 to this society. Gore also decided to sponsor the Fellows course, to pay the dues for all of the Fellows to get them in, so we'd have a continued source of dues and help us all out. Gore also has contributed through the years, and it's all due to this one individual's efforts over the last 2 or more decades. And so back in 2018, we voted to have this individual as the only non-physician member of the SCVS. And it turned out for various reasons, and COVID and other issues, we never actually formally thanked and awarded that individual. That individual is Marty Sylvain. Marty, could I have you come up here, please? I'd like to award you a certificate and thank you for everything. Absolutely, absolutely.
So I do want to say, most of you know, I work with most of the key societies and the 2 private large meetings, the Veith Symposium and Charing Cross. And this meeting is really second to none to me in the fellowship and the comradeship and how everybody feels together. So it's been and I'm not ashamed to say it, I think Dr. Veith might even be in the audience, but this is my favorite meeting that I've enjoyed over and over, and it's just an honor to have helped out in the early days. So thank you all. Yeah.
Thank you so much. All right, the first paper that's going to be presented is, of course, I need my cheaters to be able to read this. Early and midterm outcomes of fenestrated branch endovascular aortic repair in patients with or without prior history of abdominal endovascular open surgical repair. It's going to be presented by Andrea Vasurka and colleagues, and it turns out that Andrea won the Peter Samuels Award. This is our annual award for manuscripts given before the meeting to be reviewed by the awards committee, and this was voted as the best paper, so I'd like to award that now. Thank you. Perfect. So you can send it there.
Yeah.
Oh, sorry.
Yeah, of course.
Oh, sorry. Is there another? Okay. Slight height difference here. Okay.
Okay. First of all, I want to thank the Society for this great honor. And of course, I want to share this prize with also the research team at UT, which is led, of course, by Dr. Roderich. And I would like to thank the Society for the opportunity to present. These are our disclosures. Redo open surgical repair and conversions with stent graft explantation in patients with failed open or endovascular aortic repair are associated with increased mortality and morbidity. Fenestrated branch endovascular repair has been increasingly utilized to treat complex aortic aneurysms with high technical success and low mortality rates. Despite prior reports have shown that FBVAR is feasible and safe in patients with failed aortic repairs, few studies outlined the granular data that is provided here. These procedures carry many technical challenges. We often encounter a short distance between the renal arteries and the graft bifurcation, a suprarenal fixation device, an excessive amount of radiopaque markers, kinked or tortuous grafts or stent grafts, prior renal and mesenteric stents, crossed iliac limbs, and small iliofemoral access diameter. The purpose of our study was to compare early and mid-term outcomes of FBVAR to treat complex abdominal aortic aneurysms and thoracoabdominal aortic aneurysms in patients with or without history of prior EVAR or abdominal open surgical repair. This was a review of patients enrolled in a prospective non-randomized IDE study. All patients received either off-the-shelf or patient-specific device manufactured by Cook Medical. Clinical data was independently adjudicated, monitored, and reported annually to the FDA. And our endpoints were the one recommended by the SVS reporting standards. The study relocated from the Mayo Clinic to the University of Texas Health Science Center in Houston in July 2020. In this period, 506 patients were treated by FBVAR, including 380 patients which had no history of abdominal repair, 72 patients who had open surgical repair, and 54 patients who had prior EVAR. Patients had similar characteristics, except from male sex and coronary artery disease, which were lower in patients, in control patients. In terms of prior aortic history, the age at index procedure was significantly higher in control patients. Patients were older. And also, genetically triggered disease was less frequently associated with controls. Prior EVAR had more frequently suprarenal fixation devices. In terms of indication, the most common indication to treat prior EVAR was progression of aortic disease, followed by type 1A endoleak. And for prior open surgical repair, progression of the disease followed by metachronous aortic disease. Moreover, patients in the subgroup of prior open surgical repair had less frequently complex abdominal aortic aneurysm and more frequently thoracoabdominal aortic aneurysm, which were also more extensive compared with the other two groups. The characteristics of the device design and target incorporation were similar between the three groups, except from the device profile, which was significantly lower in control patients, and also patients with prior history of open surgical repair had less frequently fenestration and more frequently directional branches, and this is probably related with the more extensive aortic disease. Our technique evolved over the years. We routinely work in a hybrid operating room with advanced imaging, overhead arm position. We prefer a total femoral approach without prophylactic drain whenever possible. We often request a preloaded system, and we now move to use the unibody fenestrated bifurcated devices. And we often double stent vessels coming from the suprarenal fixation devices. In the considered population, the 30-day and in-hospital mortality was 1% overall, with no differences among the groups in terms of major adverse events. Patient survival after a mean follow-up of 30 months was significantly lower in patients with a prior open surgical repair, 45% at 5 years compared with the 59 and 63% of the other two groups. However, freedom from aortic-related mortality, which was 98% overall, was similar among the three groups. Freedom from new onset of hemodialysis was significantly lower in patients with open surgical repair, prior open surgical repair, compared with the other two groups. And overall, this rate was 97% in the whole population. Other important midterm outcomes include the freedom from type 2 endoleak and freedom from sac enlargement greater than 5 millimeters, which were significantly lower in patients with prior EVAR. So in conclusion, 1 in 4 patients treated by FBVAR had history of prior EVAR or abdominal open surgical repair. Patients who had prior open surgical repair were younger at the index procedure, more often have thoracoabdominal aortic aneurysms and devices with directional branches. FBVAR was performed with high technical success, low mortality, and similar rates of major adverse events irrespective of history of prior aortic repair. Patients treated after prior open surgical repair had lower survival and freedom from new-onset hemodialysis, likely due to differences in the extent of the aortic disease. And finally, patients treated after prior EVAR had higher rates of persistent type 2 endoleak and more often sac enlargement greater than 5 millimeters. Thank you very much again.
This paper is open for discussion. While people are coming to the microphone, the majority were obviously male. Any differences between men and women for outcomes, complications, access, etc.?
Actually, this comparison was not the focus of the analysis, so we didn't perform it in this study. But yeah, we saw that, as you said, that male sex was less associated with controls. And yeah, this is probably related to the different outcomes, of course, of female sex, especially in extensive thoracoabdominal aortic aneurysms. Yeah, that's very important.
Anil?
Yeah, thank you. This question is very important. Actually, of course, we couldn't report our procedural metrics, but I can say that the duration of the procedure and also the amount of radiation was not significantly different among the three populations. That's very surprising because we know that of course, this repair of prior open surgical or prior EVAR can be very demanding in these patients, but in our population was not different among the three groups. Thank you.
Mark Farber, Chapel. Great talk. I would have anticipated that the prior EVARs or patients with stents would have had worse renal outcomes, and you found it was in the open surgical repair group. So you said likely because of extent of disease, but you've got granular data. Can you give us any more information on that, or is that something you're going to look at further as to why those patients have a higher incidence of new onset dialysis?
Yeah. Thank you. That's a very important point. So we evaluated also this aspect about if the new onset of hemodialysis was related with a lower survival in prior open surgical repair patients. But actually, we found that only 4 patients had the new onset of hemodialysis in this group. So probably we associated more this lower survival with a more extensive aortic disease of the prior open surgical repair. That's why this population probably is more frail. Thank you.
V?
Yeah, this is probably a question for Gustavo. In terms of your management for your redo operations, whether it be an open graft or an EVAR device, what is your approach now? I'm finding that if you don't realign the entire graft, the aneurysm continues to grow. Is it type 3 endoleaks? Is it persistent type 2s? But I think, what are you doing now? Is this an evolution in practice? And also, what are you doing to manage the shorter seal zones? Are you using internalized bifurcated devices or custom devices that are short bifurcated pieces to be able to extend into your limbs?
Thank you and congratulations, Andrea. So there are a few devices for sure you should realign, and that includes an Anorex and Endologix device. Or I would say any device that is exceedingly old, older than 10 years, let's say. But several, for example, the Gore devices, we have not completely realigned. I think it's very rare to find a type 3 endoleak, and we just anchor somewhere in the iliac limbs. One of the things I would credit to actually Carlos Timaran that we moved away is inverted limbs, because inverted limbs are very short body. We have had at least 3 in the entire US ARC review that had type 3 endoleaks that are very difficult to treat. And this unibody fenestrated bifurcated device, they really perform very well. So that's something we changed, I would say, in the last year and a half. And as Andrea pointed out, if there is suprarenal fixation, although I don't have any data to tell you, I do double stent those renal stents because of the fear of compression due to difference in radial force. I think the difference in survival is because of more thoracos after open repair, and thoracos consistently have performed worse than complex abdominal aneurysms.
For time limitations, we'll let Carlos do one quick question.
Yeah, just quick.
Yes.
Are you using these unibody fenestrated bifurcated devices for patients with no previous repair? I'm just curious, because it would be an attractive option, I think.
Sorry, can you say it again? With no?
Using the unibody bifurcated fenestrated or branch devices for patients without prior repair?
No. So far, no. We don't have many cases. Dr. Rodriguez.
I know we are short on time, Carlos. We have not. I mean, traditionally, as you know, the bifurcated was designed even without barbs, so we would slide and it wouldn't compress the fenestrations. I don't know that it makes a difference, though.
Thank you very much. Thank you, sir.
The second paper is low-risk open arch repair replacement to establish a proximal landing zone for TVAR, to be presented by Dr. Danekula from the University of Washington in Seattle.
Hello. I'd like to thank the Society for inviting me to present our work. I'm a cardiac surgery resident at the University of Washington. Thank you. As everybody in this room knows, finding a stable proximal landing zone can be quite challenging in patients with pan-aneurysmal disease and chronic dissections. One of the techniques we use at our institution is a simplified modern approach to open arch surgery that improves upon some of the difficulties with classically thought open arch surgery. Shown here is our most common iteration, in which we resect up into zone 2 of the aortic arch, debranch the innominate artery in the left common carotid more proximally onto the distal ascending, and thus create 2 to 3 centimeters of parallel dacron for an easier landing zone for a TVAR. Given how frequently we use this operation, we decided to investigate our perioperative outcomes. This is a retrospective cohort study at a single institution. It included all open arch replacements from January 2019 to December 2021. We excluded all acute type A dissections, as that's a very different population in our minds. We included reoperative sternotomies with a final N of 80. Our demographics and operative data are shown here. I wanted to highlight a few points. Over half of patients had had prior cardiac surgery. They were a redo sternotomy. Around 46% of patients had a chronic type A, 18% of patients with a chronic type B, and 85% of patients received that zone 2 operation shown in one of the prior slides, so very much our most common way of addressing this. Post-operatively, we had a stroke rate of about 7.5%, about 6 patients. Again, this is in the setting of nearly over half with reoperative sternotomy and chronic dissection. No permanent spinal cord injuries, temporary spinal cord injury rate of 3.75% that resolved by discharge. Average length of stay was about 14 days or 2 weeks, and 30-day mortality was 3.75%. Subsequently, about half of patients went on to get TVAR extension. Distal to that, we had about a 10% split of patients receiving distal branched endografts and open thoracic repairs. Only 2 patients received an arch endograft during this time period, although that has changed as of late with the availability of arch branched endografts. So in our mind, contemporary open arch replacement is a reproducible, effective method for creation of a landing zone. Perioperative outcomes are similar to some of the small arch endograft trials that we have seen. They work well in tandem with arch endografts, actually, and I'll show you in the next slide. And for moving forward, we just need studies with the higher N and some of our post-TVAR outcomes. And shown here is the utility of, in this instance, the TBE in a zone 2 arch replacement. This is probably our most common way of staging these patients these days after open arch repair, and we found pretty good success with that. These are my references. Thank you so much.
So you had 60% of the cases had an antegrade TVAR at the same time. Mm-hmm. And maybe you can help me, because when we've tried this, the room setup has always been very difficult, because you have the pump, you have the II in a steep angle, you have an IVUS machine sometimes, and you have short cords on that, and you're trying to get everything, and everything seems like a cluster. So maybe you could tell me how you do that, because we've not done that much at the same time.
So we actually do not have the II machine in the room. We just use IVUS, and then we'll have the, at the same time that they're deploying a wire up towards us, we'll confirm that it is in the true lumen, and then deploy it that way. Yep.
Great. Okay.
Job, Arjun. I can also elaborate on that. A number of these are cases that we do collaboratively. So typically for these cases, if it's reasonable anatomy, meaning there's not large fens we're worried about our ability to get in and out of them, we just do them without get through and through access and then go antegrade. That has changed dramatically, I would say, in the last, really since September. And now these cases are almost universally getting zone 2 TBEs. So we're not there really at all. So it's a big shift in practice. I will say if it's a patient whose anatomy we're very concerned about, we will do it in a hybrid room, but that's the minority of cases today.
Great. Thank you.
Thank you so much.
Next, we have endovascular repair of ruptured complex aortic aneurysm using chimney snorkel parallel grafts. The presenter will be Lauren Grimsley from Kentucky.
Thank you so much. Thank you so much for the opportunity to present. I'm Lauren Grimsley. I'm the second-year fellow at University of Kentucky, and we'd like to present our experience with complex ruptured aneurysms that have been repaired endovascularly, specifically using parallel grafts. This is a retrospective review of a single institution from January 2010 to February 2022, and we were primarily wanting to look at mortality. 30-day mortality is our primary outcome, and then parallel graft patency, secondary graft intervention, and major complications as our secondary outcomes. There are different parallel graft techniques. We utilize Eye of the Tiger, as you can see here in the schematic. First, the stent is deployed, then overexpanded, then crushed by an aortic balloon, and then re-expanded to get that lens shape on IVUS and CT images, and this technique was used in about 80% of the cases. This is a representative schematic demonstrating our process in parallel grafting, creating a seal in healthy aorta proximally, and ideally at least 4 centimeters proximal seal, and then maximizing our sandwich seal of our parallel stents at least 5 centimeters in length. And again, this is demonstrating a different technique of maximizing our parallel graft sandwich seal of 5 centimeters. 19 patients in our cohort with a total of 44 parallel grafts. The median age of the patient population was 68. 13 patients were men, and interestingly, almost half of our patient population had undergone previous aortic surgery. 16 of the 19 patients were transfers to the University of Kentucky. 3 patients died within 30 days. 3 patients suffered major complications. The average length of stay for our cohort was 9 days. And 5 patients had endoleaks. However, only 3 of those were intervened upon. I'll speak about that now. So patient 7 had a type 1A endoleak that underwent proximal extension and reinforcement of the SMA and bilateral renal stents post-op day 4. Patient 12 had a type 1C endoleak that underwent extension of a right renal stent to get better seal post-op day 6 from initial surgery that resolved the endoleak. Patient 17 had a type 1C endoleak at the conclusion of the case with no intervention, and then that resolved on follow-up scans 1 month later. And then patient 18 had a type 2 endoleak that 3 months after his initial surgery underwent translumbar coil embolization. However, he still remained to have a type 5 endoleak. Of the deaths, patient 4 had a stroke on post-op day 1, and the family elected to pursue comfort care. Patient 5 developed mesenteric ischemia, underwent a colectomy, and then became increasingly unstable and died. And then patient 7 originally presented not only with a ruptured aneurysm, but also a fall pre-hospital, and then developed acute renal failure, and the family elected to pursue comfort measures, and he died post-op day 7. This table demonstrates the patency rates in months of the cohort, and I'll go into detail a little bit more in the next slide. So patient 11 presented to the hospital with a stroke and an acute renal failure 22 months after his initial surgery. Bilateral renal stents were found to be thrombosed, and he was not a candidate due to lysis because of his stroke. However, his celiac and SMA stents remained patent on his subsequent follow-up. And patient 17 had some celiac artery stenosis on follow-up imaging that underwent restent angioplasty 10 months after the initial surgery. There are limitations to this study that include single center, it's retrospective, it's a very small sample size, and UK is a high volume parallel graft center, so these results may not be applicable to every institution. However, I believe that parallel grafts are a safe and effective way to treat ruptured complex aneurysms with acceptable risk. Thank you.
Linda?
So, very interesting study. My question has to do with the endoleaks. Endoleaks in a non-rupture, not a big deal. But many of us believe that endoleaks in a rupture can lead to compartment syndrome or continuing hemorrhage. So did you have any compartment syndrome in your series, or how could you walk out of the OR with a leak in a person who was ruptured, or are these all just really contained ruptures and the patients were uber stable? Thank you.
These were true ruptures in our patient population. None of them developed compartment syndrome. And for example, the patient that had a 1C endoleak that we elected to do nothing about, once we get the graft in place and get some access or get a coda balloon in place, we'll heparinize to some degree. And sometimes we think, it could just be related to the physiology of the rupture and requiring transfusion and those kinds of things. And this is kind of the hard part to quantify because, you accept some risk of that endoleak, but at the same time, we wouldn't leave if it was a blaring 1A endoleak. We did not have any patients that developed abdominal compartment syndrome from the rupture.
Gustavo Aldrich, Houston. Can you give a little more context? Because 19 thoracoabdominal ruptures are a lot. I mean, we've done hundreds of these, and I don't know that I have 19 ruptures. So what do you do for the elective, and how many electives have you treated in the study interval?
So I believe in the study interval, we had about 400 patients of that 12-year period, and that's over 7 surgeons, that were treated electively, non-ruptured. And so it is a technique that we're fairly facile with, the staff is very facile with, and I think that's why we feel confident. We still do some open thoracoabdominal ruptures that are appropriate candidates. And so we feel that the 19 that were selected for endovascular treatment were stable enough to undergo it, had appropriate anatomy that we thought would be successful. Otherwise, they would undergo an open repair.
David, did you want to comment?
I just wanted to follow up on Dr. Harris's question. We don't leave the room with the endoleak. That's why we do the eye of the tiger. So the tiger removes the endoleak, and that's part of the reason why I don't think you can, if you're not doing eye of the tiger, you can't do these ruptured. And we had 4 endoleaks. 1 was a type 2, 3 were found. It's hard on a thoracoabdominal to see what is the endoleak from. If you have a little bit of sac filling or so forth. So yeah, we don't intentionally leave with endoleaks. I just want to clarify that.
Thank you. Jim, you have a real quick question?
Yes, Jim McKenzie, New York. Great presentation. Looking at how many of these were 4 vessels, or were you doing a combination 2, 3 going up? And then what's your sequence when you're doing the eye of the tiger? Do you still, if you're doing 4, do you blow 4 balloons in one aortic balloon, or can you do it more staged since you're really kind of post-dilating once you've already crushed?
Oh, great question. I wonder if I can I go back to my presentation really quick? if it'll allow me. Oh, perfect. Thank you so much. So there were 5 patients that underwent 4 vessels, 8 patients that underwent 3 vessel, 3 patients that underwent 2 vessel, and 3 patients that underwent 1 vessel parallel graft. And these could be, typically for the 1 vessel, it was a renal. For 2 vessel, it could be a renal. But however, one of our patients was already on dialysis, presented with a rupture. We elected to cover his renals because he was already on dialysis, and so we just parallel grafted his celiac and his SMA. As far as the sequence of events, I'll see if I can scroll back here. Generally, we like to proceed getting endovascular control and putting our EVAR up, then cannulating our branches, whichever branches we are going to be cannulating, and then placing our TVAR in place or our cuffs to cover over those areas. Depending on how spaced out our visceral vessels are, sometimes we will have to blow up an aortic balloon in different segments of it in order to get our seal and our appropriate crushing. There was one more question at the end. I'm sorry.
I think that we ran out of time. Thank you very much.
Okay, perfect. All right.
Thanks.
Thank you.
All right, thank you.
So the next paper is general anesthesia is associated with greater hemodynamic fluctuations, but no difference in mortality during endovascular repair of ruptured abdominal aortic aneurysm. To be presented by Dr. Bowen Chi from UPMC in Pittsburgh.
Good afternoon. Thank you for the opportunity to present our research. We have no disclosures. So EVAR has been a well-established and accepted treatment modality for ruptured abdominal aortic aneurysms. However, recently there's been some evidence of an increased mortality signal associated with general anesthesia as compared to local in the setting of ruptured EVARs. These studies lack the granularity and data to determine the intraoperative effects of the anesthesia types, so we therefore aim to examine the hemodynamic effects of anesthesia modality in the setting of ruptured EVARs. This was a single healthcare system retrospective review from 2015 to 2020 of patients who underwent EVAR for ruptured AAAs. After excluding those who were already intubated on arrival, the remaining patients were grouped into 3 cohorts: those who underwent moderate anesthesia care or local anesthesia, those who underwent general anesthesia, and then those who underwent conversion from MAC to general intra-op. The primary outcome of the study were post-induction blood pressure fluctuations as well as vasopressor usage, and the secondary outcomes included 30-day mortality and post-operative morbidity. In terms of preoperative characteristics, the patients in the conversion cohort presented with a lower preoperative systolic blood pressure, while the patients in the general anesthesia cohort had a significantly longer preoperative anesthesia induction time, as well as a higher usage of cardiodepressive induction agents. Looking at post-induction blood pressure fluctuations, there was a consistent and significant drop in blood pressure post-induction with the general anesthesia group, while the patients in the MAC group had a significantly lower proportional usage of either intermittent or continuous vasopressor support post-induction. And looking at outcomes based on an intent to treat approach, we found no significant difference in 30-day survival between general or MAC on Kaplan-Meier analysis, nor was there any significant difference in the postoperative complications between the 2 groups. Furthermore, there was also no association between 30-day mortality or anesthesia modality on our multivariate model. However, when we separate out the conversion group from those who went exclusively under MAC, there was a non-significant but somewhat trend towards increased rate of complications within that conversion group. So in conclusion, we found that there was, in fact, a greater degree of systolic blood pressure fluctuation and vasopressor usage in patients who underwent general anesthesia as compared to local in the setting of ruptured EVARs. However, there was no difference in either 30-day mortality or morbidity, but a trend towards potentially increased postoperative complications in those who underwent intraoperative conversion. This leads us to believe that a MAC-first approach may help to reduce the hemodynamic volatility that may be present in the setting of ruptured EVARs, but careful patient selection is required as the necessity for conversion may lead to worsening postoperative outcomes. Thank you very much for your time.
Dr. Timoran?
Yes, Carlos Timoran from Dallas. Nice presentation. The IMPROVE trial in the UK, which was randomized, and compared endo versus open, clearly demonstrated the only factor that improves survival in these patients is the use of local anesthesia. And obviously in patients that undergo EVAR. So I think that's important. And I think we have to take that into consideration. Having said that, what's your approach, your protocol? Do you always try to do local anesthesia first? What kind of imaging you get first? And, or do you always consider general from the get-go?
That's a great question. So we have a rupture protocol in place in our institution where when a rupture is called in, the imaging gets uploaded through some online server, and there's a discussion between us and our anesthesia colleagues in terms of what type of anesthesia is preferred. Ultimately, that ends up really kind of being their decision in terms of what they feel most comfortable with. I think in the setting of patients who come in, an extremis and they're concerned about airway compromise, really you have to go general. But again, that's a discussion we need to have essentially with our anesthesia colleagues.
So that goes to my question. So our protocol is that you do local anesthesia and get access before general anesthesia, just in case the patient crashes with general anesthesia. How did you count those patients as being general? If you end up doing general, so that's a general patient?
Correct.
Okay.
So the conversion ones were the ones that started with local, and then if they were converted at some point intra-op, that is a conversion. The general ones essentially started general.
Cool. Yeah, I can probably shed some light on that. So thanks for your question, Carlos. So our institution over the last 10 years has moved primarily to an EVAR first, local anesthesia first approach to all of our endovascular. We're probably about 60% endovascular, 40% open, just because a lot of these are pararenal or juxtarenal. So what you see there is probably only about 60% of what we see. So we try really hard to do a local approach first, but a lot of times if things are really, really tenuous or we're not sure that we have to open, then our anesthesia colleagues will do that. So we've done a really good job of being collaborative, multidisciplinary, and so most of our anesthesiologists who work with us on ruptures are really cognizant of using less cardiodepressive agents. But just because we had amassed such a large amount, we thought it would be useful to study. I think probably the thing that surprised us the most was that in our series of 120, there wasn't that much difference between the local and the general, and I think that probably it kind of goes to show that if you have a good protocol in place, probably how the patient presents is much more important than what kind of anesthesia you're putting them through.
Great. Thank you.
Thank you.
All right. The next paper is titled Comparison of Fenestrated Stent Graft Designs Using Proximal Bare Metal or Non-Bare Metal Fixation by Dr. Lima and colleagues from the Mayo Clinic in Rochester and the University of Texas Health Science in Houston.
Good afternoon, and thank you for the opportunity to present. These are our disclosures. Proximal bare metal fixation stents are intended to decrease the risk of migration, and they're specially used for infrarenal EVARs pursuing suprarenal fixation. However, the role of bare metal fixation stents for fenestrated and branched EVAR is not well established. It might be able to provide better rotation movement to facilitate vessel catheterization. However, novel designs with bare metal fixation stents, without bare metal fixation stents, they might have lower profiles. However, there is also concern that this might lead to type 1A endoleak, compromising the proximal seal. The purpose of this study was to evaluate procedural metrics and outcomes of fenestrated endovascular repair using devices with and without bare metal fixation stents. In order to do so, we did a retrospective review of a prospective investigational device exemption study, and we included only patients treated with 4-vessel fenestrated stent grafts with and without bare metal fixation stents. We excluded extent 1 to 3 thoracoabdominal aortic aneurysms. We studied procedural metrics, also 30-day outcomes, and midterm outcomes, which included freedom from any reintervention, freedom from type 1A endoleak, and patient survival. At the point of this study, we had 502 patients enrolled in the IDE study, and we included in this analysis 147 patients. 79 had bare metal fixation stents, and 68 didn't. Groups were comparable, besides cigarette smoking, which had a higher proportion in the bare metal group. Patients that underwent had a bare metal fixation stent had a higher proportion of pararenal aneurysms. And regarding procedural variables, technical success was 99% and was very similar among both groups. Total operating time was higher in the bare metal fixation stent group. However, total endovascular time, fluoroscopy time, radiation exposure, and also contrast was comparable among groups. 30-day mortality was low, 1%, and was the same in both groups. And overall, 14% of the patients experienced any kind of major adverse events, and this was also comparable among groups. We had only one early reintervention related to femoral access complication, and that patient was on the bare metal fixation stent group. Patient survival overall was 85% at 3 years, and there was no difference among groups. Freedom from secondary intervention was 80% and 3 years, and was also comparable between both groups. We had no type 1A endoleak in the follow-up. And target vessel patency was 97% and 3 years, and this was also similar in both groups. In conclusion, FEVAR for complex abdominal aortic aneurysms and extent 4 thoracals was performed with high technical success, low mortality, and major adverse events in both groups, and there was no difference in patient survival, target vessel patency, and freedom from secondary interventions in patients treated with or without bare metal fixation stents. Thank you.
I guess, could you just explain to me, why did it have to be 4 vessel? Why not a 3 vessel, et cetera? And second would be, based on these data, is a 4 vessel here now the gold standard? Open surgery is no longer the gold standard based on the excellent outcomes, at least in your group's practice?
That's a great idea, great question and great comment. Thank you for that. So answering the first question, I mean, the reason why we only included 4 vessels is just to have really a reliable comparison among both groups. We wanted patients with 4 vessels and 4 vessels in each group for fenestration so that we could have a very, really clear and transparent comparison. We could probably have included a patient with 3 vessels, but again, that was the reason. And I guess, I mean, in our practice, well, Dr. Schroeder's practice, I would say that most part of these patients, yes, they would go to open repair unless patients with genetic diseases or very young patient, fit patients, they could do open surgery, but overall, in our patient population, they would do endo procedures with these outcomes, yes.
Just a quick comment to you and maybe the primary author. The whole idea way back in the day of putting the bare metal things is to avoid migration, and knowing that these stents are really just kept in by friction. Are you worried about the long-term effect if we start moving away from doing fixation in the thoracic aorta, particularly with 4 different branches that are sort of dangling in there? Just curious.
Sure, that's a great question, and that's what we're trying to answer with this paper. I'll say that overall, with longer-term follow-up, although we don't have the bare metal fixation stents, these stent grafts, they do have active fixation with barbs. And again, to see the long-term follow-up, we need to follow these patients. We don't have an answer for that. Our feeling is that they are going to do well over time. I cannot answer that right now, though. Thank you.
All right, Mark, as long as it's a quick question, we're otherwise out of time. Sorry, V.
Jeremy, there's probably a selection bias in your data, and that's because most of us use the bare stents, use the dark gray dilator, which tracks better through tortuosities than previous endografts. So did you look at any of that aspect of it? Because that may account for a difference, because this is not just a randomization.
I agree with your comment, and I thank you for that. However, I mean, I don't know regarding tortuosity if there is a difference among groups. As I showed before, there's definitely a difference in extent of aneurysm among both groups, and that can be actually one of the reasons for our outcomes.
Great. Thank you.
Thank you.
The next one is a video, FEVAR with physician-modified endovascular graft using fiber optic real-shape FORS technology, to be presented by Dr. Nicholas Swerdlow from Beth Israel Deaconess in Boston.
Thank you for the opportunity to present our work. We have no disclosures. This video demonstrates the use of fiber optic reel shape or FORS technology during a fenestrated endovascular repair with a physician-modified endograft. FORS technology is a groundbreaking radiation-free endovascular imaging system. The FORS wire and catheter are capable of sensing shape in three-dimensional location and space, and this allows for manipulation with minimal radiation and contrast use. Here we see the FORS setup, including the dock attached to the OR table and the attached hardware unit. The case we present is a 78-year-old woman with a 54 millimeter suprarenal AAA. She has a history of hypertension and COPD and is a former smoker. She did not have connective tissue disorder, but did have multiple family members with aortic disease. Here we see axial cuts of her CTA demonstrating the suprarenal AAA, followed by centerline coronal and sagittal images, which demonstrate the maximum diameter of 54 millimeters in the infrarenal aorta and 32 millimeters in the visceral segment. She was considered too high risk for open repair and given her age and comorbidities, and therefore she was offered a fenestrated EVAR with a PMEG as part of her FDA-approved IDE study. For this case, we used a 34 to 30 by 161 millimeter Cook alpha thoracic proximal taper component with 4 fenestrations for the celiac, SMA, and bilateral renal arteries. When using the FORS, the first step is shape registration. Here we can see the process of registering the wire and catheter intraoperatively. Once registration is complete, the location of the tip of the wire is then verified. And once verified, we are ready for intraoperative use. Next, we see the PMEG having been inserted and our image fusion software aligned, and we are cannulating the left renal artery using the FORS wire and catheter, all within a Tor guide sheath. Once the catheter is advanced, we'll then use contrast ejection to confirm the position of our catheter and ultimately exchange for our stiff wire. Moving on to the SMA, we can see the ability to use 2 views simultaneously, including both standard fluoroscopy imaging with contrast injection and the CTA reconstruction. Once again, once the catheter has been advanced into the proximal SMA, we can use stored contrast ejection, again with just standard fluoroscopy as opposed to DSA, to navigate into a large distal branch. And here you can see that standard fluoroscopy again. Moving on from there, we'll next see the right renal artery. With the right renal, we use the stored end-on view of the fenestration in conjunction with the AP alignment of the CTA reconstruction, again giving 2 views of the anatomy. Due to tortuosity here, we ultimately switched to a standard glide wire and used standard fluoroscopy for navigation of the distal renal artery. Again, advancing our catheter distally and exchanging for a stiff wire. And then finally, for the celiac artery, we see the ability to adjust the image fusion mask from the table intraoperatively. So during this case, we found that it was easier to cannulate the hepatic artery and ultimately the GDA. We had initially prepared for cannulating the splenic artery, so here we can see adding those arteries to our mask intraoperatively. Ultimately, we then navigate using that guidance to the GDA and then exchange for our stiff wire and move on to our visceral artery stenting. So with all our target vessels cannulated, we can see here popping the temporary constraining wires using a coda balloon and then deploying our visceral stent with an example here of the celiac artery. Once the stent is deployed, we always use contrast injection to ensure no endoleak and good flow. And finally, we can see the FORS being used to cannulate the contralateral gate in 2 different views of the anatomy. Completion angiogram demonstrated the patency of all 4 visceral vessels with good proximal and distal seal. So in conclusion, FORS has introduced a new paradigm in endovascular imaging, Using FORS, we've been able to complete our last 5 4-vessel PMEGs with between 180 and 350 milligray of radiation. This technology is an important step in decreasing the dependence on radiation during these procedures and may ultimately help obviate the need for radiation altogether. Thank you.
Can you just tell us about the learning curve here? Like, how long is that? And is there any simulation or anything like that that can lessen the learning curve?
Excellent question. I think the learning curve it's kind of twofold. One is just the ability to kind of navigate the different system, and a lot of it has to do with actually, I think, the imaging system itself and not intraoperatively, like just how it works with your current imaging system. And then I think there is a learning curve that simulation does not account for, which is understanding the limitations of the wire and catheter. It's based on a standard Terumo glide, but it doesn't behave exactly the same. So knowing when you need to accept that that wire is not going to work for either a tortuous lesion or a tight lesion and switch over to a standard glide wire or some other wire. And I think we've learned that over, definitely, probably 15, 20 cases where it really became clear.
I guess, Anil, as long as it's a quick question.
How much does it cost?
So I don't have the cost data, and I would talk to Phillips about it, but it's something that's very new. There's only 5 sites in the U.S., and it's going to take time. But I think that's something that, with more competition from other systems, and I think the cost will come down ultimately.
Thank you.
Okay, thank you. All right. The next presentation is complicated versus high-risk patients undergoing thoracic endovascular aortic repair for acute type B aortic dissection by Dr. Filiberto and colleagues from University of Florida, Gainesville.
Hi, my name is Amanda Filiberto, and I'm a chief resident at the University of Florida, and thank you for the opportunity to present. We have no disclosures. So acute aortic dissection is the most common emergency affecting the human aorta, and it's associated with high morbidity and mortality if not treated appropriately in a time-sensitive manner. Management of acute type B aortic dissections has evolved over time and now includes medical, surgical, and endovascular therapies performed by several specialties. There's been an abundance of literature recently in multiple specialty journals regarding TBAD presentation, treatment, and outcomes. So in 2020, the SVS and the STS got together and came up with a consensus on reporting, nomenclature, and classification of TBADs. Of note, historically, patients with uncomplicated TBADs, so without rupture or malperfusion, were treated medically, and patients with complicated TBADs were repaired with an open or an endovascular approach. So the recent SVS-STS guidelines now define complicated versus uncomplicated type B aortic dissections with a new high-risk grouping. So the Society for Vascular Surgery and the Society of Thoracic Surgery reporting standards for type B aortic dissections are shown here. The high-risk group includes patients with refractory pain or hypertension and those with high-risk radiographic features. So if symptoms persist for greater than 12 hours despite maximal medical therapy, that's when it's considered refractory. So the objective of our study was to evaluate patients undergoing TVAR for acute type B aortic dissections stratified by high risk versus complicated, as defined by the 2020 SVS and STS reporting standards in terms of demographics, clinical presentation, symptom onset, and outcomes. So we did a retrospective chart review of patients undergoing TVAR for acute TBADs from 2005 to 2020 at a single institution and included a total of 101 patients. Primary endpoints were inpatient mortality, secondary was complications, reintervention, and survival. Logistic regression was used for risk-adjusted comparisons, and life table methodology estimated freedom from endpoints. So our cohort was composed of 63 patients with complicated TBADs and 38 patients with high-risk features. There were no differences in terms of age, sex, or BMI. Patients in the complicated cohort had higher ASA classification, and there was no difference in terms of onset of symptoms to hospital admission. As expected, patients with complicated TBADs were repaired with a median of 0 days as compared with the high-risk group, who were repaired with a median of 3.5 days. The patient outcomes are shown here, where there were no differences in length of hospital stay or rate of reintervention between the two cohorts. There are no differences in postoperative morbidities other than complicated patients had a higher incidence of renal complications at 21% versus 5% in the high risk. In hospital, 60-day and all-cause mortality were higher in the complicated cohort. Patients with complicated TBADs had poor long-term survival at 70, 65, and 61% versus 100%, 93%, and 88% at 1, 3, and 5 years. Although dissections without overt malperfusion or rupture may not be immediately life-threatening, high-risk, uncomplicated dissection is associated with substantial risk and complications. Consistent with the STS and SVS guidelines, patients with acute complicated TBADs undergoing TEVAR have poor perioperative and long-term outcomes as compared to those with just high-risk features. These findings may improve preoperative surgical risk stratification and patient counseling, and it appears that TEVARs for high-risk TBAD is safe, and the potential long-term benefits and/or timing of intervention have yet to be defined, and additional studies are warranted. I'd be happy to take any questions.
Can you walk us through your high-risk protocol? Is there anything in particular, any radiographic findings, false lumens, aortic size, et cetera, patency, all that stuff?
Yes.
How you treat?
Yeah, so that's a great point. So traditionally, clinical parameters used to be the main inclusion for complicated, so just refractory hypertension on three different types of medications for greater than 12 hours, or severe pain despite pain medications and anxiolytics. And then I already talked about the pain, same thing, pain medications and anxiolytics. So in terms of the radiographic, this is the first time they've really sort of been clearly defined, and this is sort of what we follow at University of Florida. False lumen diameter greater than 22, and then aortic diameter greater than 40. It's pretty granular data, and so to go back through a retrospective chart review, it takes a lot, but these are the criteria that we use.
All right, thank you.
Thank you.
The next paper is an international collaboration. The title is Sex-Related Outcomes After Thoracic Endovascular Repair for Intact Isolated Descending Thoracic Aortic Aneurysms, to be presented by Dr. Sarah Alievi from the Division of Vascular and Endovascular Surgery at Beth Israel.
Thank you. Good afternoon, everyone. Thanks for the possibility to present our project. I have no disclosure. Prior studies have already reported conflicting results regarding sex-related outcomes after TEVAR for thoracic aneurysm repair, and data regarding long-term outcomes are lacking. Thereafter, we decided to do a study which evaluates the association between sex and outcomes after TEVAR for intact isolated descending thoracic aortic aneurysm. We perform a retrospective studies with all the patients undergoing TEVAR for this pathology between 2014 and 2022 in BQI linked to Medicare, stratified by sex, and we excluded patients with rupture and prior aortic repair. Our primary outcomes were 5-year outcomes, and secondary, we look at perioperative mortality and in-hospital complication. Our final cohort included 700 patients, of which 54% were female. Here we can see the baseline characteristics. Female were more frequently black, but less frequently presented with diabetes, prior cardiac intervention, and they had also larger aortic side index, despite a maximum aortic diameter, which was comparable between sexes. They had also more frequently a symptomatic presentation. Regarding the procedure, we can see that female more frequently had more than one stent graft, despite the total aortic coverage was comparable. They had also more iliac concomitant procedure and a longer total procedural time. Here we can see the primary outcomes, and from the graph we can see that 5-year survival was comparable between male and sex, even after adjustment. Same for late reintervention and rupture. Regarding our secondary outcomes, we can see that perioperative mortality is comparable, or at least not statistically significant, and also in hospital complication as composite outcomes as well as independent variables. In conclusion, we can say that females who undergo TEVAR for intact isolated descending thoracic aortic aneurysm have similar 5-year outcomes as compared to males. And even though females were more frequently symptomatic at presentation had more iliac concomitant procedure, we couldn't find any statistically significant differences in perioperative mortality and in hospital complication. Further studies are needed to better understand sex-related outcomes and develop specific protocols for risk stratification, treatment, and follow-up. Thank you.
So it looks like this is a truly international collaboration.
Yes.
So I may have missed this. How long did the study cover?
This study from 2014 up to 2022.
Were there any percutaneous cases?
Yes.
And roughly what percent were percutaneous?
The majority of patients had, I couldn't remember exactly the percentage, but yes, it was definitely like more frequently percutaneous, like 80% probably.
Great. Any questions from the floor?
And the longer procedure times in women, was that mainly due to access issues, such as?
Yeah, probably it was due to the small difference in access type. But we couldn't find any complication also access related.
Was there more conduits, crack and pave, cut downs, etc.?
Like in VQI, there are multiple variables for access procedure. So like, for example, PTA or iliac conduit. So actually, given the fact that we have only 700 patients, we have also few number of, so.
Okay. Thank you very much.
Thank you.
All right. Next is a comparison of surgical techniques and outcomes for primary mycotic aortic aneurysms by Dr. Simon at University of Pittsburgh.
Hello, everyone. My name is Dana Saman. I'm a research fellow at UPMC. Thank you for this opportunity to present our work here today. We don't have any disclosures. Although mycotic abdominal aortic aneurysms are rare, they are associated with significant mortality and morbidity. So, the treatment for these aneurysms include IV antibiotics and surgery. The surgical approaches can include endovascular repair with EVAR, open aneurysm repair in situ, or extra-anatomic bypass repair. However, there are no studies that compare all three surgical techniques. As such, our aim is to compare the short and long-term outcomes of these techniques in treating primary mycotic abdominal aortic aneurysms. This was a retrospective cohort study in a large multi-hospital single-institution network. Primary mycotic aneurysm was defined as the presence of abdominal aortic aneurysm with evidence of infection in a patient with no prior history of aneurysm repair. Evidence of infection was seen either on clinical presentation, lab markers, on imaging, or during surgery. Our primary outcomes included all-cause mortality at 30 days, 1 year, and 5 years, while secondary outcomes included postoperative outcomes, 30-day major complications, and 30-day aneurysm-related mortality. There were 43 patients included in our study, and the three techniques were distributed evenly among them. Patients undergoing EVAR more often had diabetes, end-stage renal disease, and coronary artery disease, and EVAR was also more often performed in patients with a saccular aneurysm. 53.5% of the entire cohort presented with rupture. However, there was no difference in presentation between the three techniques. Kaplan-Meier survival estimates at 30 days and at 1 year did not show any significant difference between the three groups. However, open aneurysm repair in situ did offer significantly improved survival at 5 years, while EVAR had the lowest rate of survival. Estimated blood loss and the need for PAC transfusion were significantly different between the three, with EVAR having the lowest blood loss and extra anatomic repair having the highest blood loss and also need for transfusion. 30-day major complications were non-significantly different between the three groups, with extra anatomic repair having almost 50% complication rate. 30-day aneurysm-related mortality occurred exclusively in the extra anatomic repair group. Reinfection occurred in 12.5% of patients undergoing EVAR at an average time of 1 year postoperatively. In conclusion, the repair of primary mycotic aortic aneurysm is associated with high complication and mortality regardless of the approach. In our studied sample, open aneurysm repair in situ offered an improved long-term survival without any added benefits in terms of complication rates. And given the lower long-term survival among patients undergoing EVAR, it should be considered as a bridging stage between the urgent situation and the eventual repair. Thank you.
I guess I'd focus on that last comment about could you tell us about crossover? How many patients crossed over from one group to another? And how often do you employ the EVAR with the staged explant open surgical approach?
So thank you for that question. So we did not include these patients in our study. We only include patients who had EVAR and did not undergo any explantation or reconstruction. However, it's important to note that the patients who did have EVAR, a lot of them did receive lifelong antibiotics. However, we don't have exact numbers because it's very difficult to get that follow-up granular data from the patients.
Linda?
2 questions. Number one, do you have any information on the infections? Were they similar between the groups or different? And how did you treat them in terms of antibiotics long-term? Because that's a big thing. And the other is more of a comment, which is I think you're comparing 2 different groups. The open patients, this was retrospective, and you already said there are differences in other types of morbidity and comorbidities. So do you really think there's a big difference there, or do you think it's the nature of their diseases that cause the mortality? Thanks.
Thank you for that question. So for the first one, I know that there were 2 patients in the EVAR group who had infection that required explant. So we don't have data on patients who had any type of recurrent infection. We only looked at the patient who required a reintervention. And there were also 2 patients in the open aneurysm repair in situ group who had infections. So they were similar. However, it's important to note that the patients in the open repair group did not have any mortality, while both patients in the EVAR group did eventually pass away. As for your second question, I'm not really sure, to be honest, regarding the differences.
Dr. Glavitsky.
I just have a brief question. You had 1 patient who had infected aneurysm that was a fungal infection. So
yes.
You keep calling that mycotic aneurysm. Why are you doing that?
Yes, it's just to keep in with tradition, I guess. It should be called infected abdominal aortic aneurysms, I agree.
A very nice presentation.
Thank you.
So you said that if you did an EVAR that they should be staged. At what point would you stage them?
Well, I'm not really sure. I guess that depends on the severity of the disease for each patient, how stable they are, the extent of the infection. But I guess the longer you wait, then the more difficult it would be. So, not really sure.
When? Okay.
I'm not sure.
All right. Thank you.
Thank you.
The next paper is Outcomes Following Thoracic Endovascular Aortic Repair for Blunt Thoracic Aortic Injury, stratified by Society for Vascular Surgery Aortic Injury Grade, to be presented by Dr. Sai Yadavali from Beth Israel Deaconess. And this is also a collaborative paper.
Good afternoon. Thank you for the opportunity to present. Thank you. In 2011, the SVS adopted an anatomical classification system for blunt thoracic aortic injuries and suggested that grade 1 injuries or intermittent tear should undergo medical management, while grade 2 to 4 require operative repair. Studies that included patients which had both medical management and operative repair found an association between SVS aortic injury grade and mortality. However, in those undergoing TVAR, grade was not found to be associated with mortality, and grade-based outcomes have not been reported yet. Therefore, we examined perioperative outcomes and 5-year mortality in patients treated with TVAR for BTAI, stratified by SVS aortic injury grade. Secondarily, we evaluated the trends of proportions of SVS aortic injury grades of patients undergoing TVAR over time. We performed a retrospective cohort study of the VQI of patients undergoing TVAR in aortic zones 2 to 5 between 2013 to 2022, excluding those who did not have information regarding their aortic injury grade. Our outcomes were peri-op mortality, in-hospital complications, in-hospital reintervention, 5-year survival, and trends. At baseline, patients in all 4 grades were comparable. Grade 4 patients had lower GCS scores, higher rates of chest injury, and higher rates of other coexisting injuries as evidenced by very severe ISS category. Grade 1 patients were more likely to undergo elective repair, while grade 4 was more likely to undergo emergent repair within 4 hours. However, even low-grade injuries were repaired within 4 hours in up to 50%. Grade 1 patients had higher likelihood of having distal extension beyond zone 5, higher rates of preoperative spinal drain placement, while coverage of the aorta was longer in grade 4. Looking at perioperative outcomes, higher mortality rate was seen in higher grade injuries, along with higher aortic-related mortality. However, strikingly, we found high rate of spinal cord ischemia in grade 1 and high rate of stroke in grade 2. After risk adjustment for coexisting injuries and other baseline characteristics, there was no association between grade and outcomes in these patients. 5-year survival was lower in grade 4. However, again, after risk adjustment, there was no association. Over time, we found that at least 5% of patients undergoing TVAR had a grade 1 injuries, and this proportion did not decrease over time. In conclusion, following TVAR for BTI, the perioperative and 5-year mortality rates were higher in higher injury grades, but after adjusting for coexisting injuries, there was no association seen. Grade 1 patients had a high rate of spinal cord ischemia that is potentially attributable to the TVAR they underwent. Over 5% of grade 1 injuries, despite the SVS guidelines, still did undergo TVAR, and this proportion did not decrease over time. Further efforts should focus on enabling careful patient selection for those who need TVAR among the BTI patients and preventing the inadvertent use of TVAR in low-grade injuries. Thank you.
I may have missed it in the presentation. How many patients had intentional coverage of the left subclavian?
I was up to, if I can go back to my slides, I can give you the percentage. 28% had either coverage or revascularization in grade 1, and it was up to 30% overall.
So it's either or? Okay.
Yeah.
Mark?
Thanks. The Gore original pivotal study excluded everyone with ISS over 75 because early data says none of those patients will survive. Did any of your patients with an ISS over 75 survive? And if not, should we change the guidelines and say we shouldn't be treating those patients?
We did not exclude patients who had ISS over 75. Was the question, I'm sorry, I did not really get the question. Are you saying that we should change guidelines to not do TVAR in these patients?
Did you have anyone with an ISS over 75 that lived? And if not, should the societies think about changing guidelines and saying we shouldn't be treating those patients if they're that injured because they're not going to survive?
Yes, thank you for the question. I think that's a great point, but unfortunately, I cannot give you the exact number of those who survived with an ISS more than 75. But I do agree that if a patient is unsurvivable, there's probably no advantage of them undergoing a TVAR.
Thank you very much.
Thank you.
All right. The next paper is comparing aortic graft sizing between IVUS and CTA for blunt thoracic aortic injury, patients undergoing TVAR, to be presented by Dr. Shaper and colleagues at St. Louis.
Good afternoon. Thank you for the opportunity to present our findings. We have no disclosures to report. TVAR is the preferred method for treating blunt thoracic aortic injuries with outcomes dependent upon the use of appropriately sized stent grafts. Previous studies have demonstrated the possibility that CTA measurements lead to surgeons undersizing aortic grafts compared to patients whose aortic measurements are determined by IVUS, which could be due to hemorrhage in the setting of trauma, decreasing blood volumes during CTA. In this study, we used data from the Aortic Trauma Foundation database, which contains over 1,000 subjects from 44 centers across North America and Europe, and aims to collect data on the diagnosis, management, surveillance, and outcomes after BTAI. We identified differences between graft sizes used during TVAR and aortic diameter measurements obtained from CTA, and compared this difference between patients undergoing IVUS and those that did not have IVUS. We also analyzed differences in demographics and other variables between these two groups. Chi-squared, Fisher's exact, and two-tailed t-tests were used. Between 2004 and 2021, 928 blunt thoracic aortic injury patients were entered into this database. 293 of those met criteria to be included in this study. 124 cases used IVUS and 169 did not. There were no significant differences in the included comorbidities between the IVUS and non-IVUS groups. Patients in the IVUS group had significantly lower preoperative creatinine than in the non-IVUS group, but there were no significant differences in the other included preoperative characteristics. The difference between the aortic diameter as measured by CTA and the actual endograft size in millimeters is represented by delta D. There was no difference in delta D between groups, both proximally and distally. There was also no difference in the average proximal and distal graft diameters between groups. There were no differences in other included pre-op characteristics. There was one post-op cerebrovascular accident in the IVUS group and 12 in the non-IVUS group, which was statistically significant. However, there were no significant differences in the other included post-operative outcomes, which are listed in this table. As with any study, there were limitations. Our cohort was limited to 293 patients, and a larger group would make the conclusion stronger. And in the future, we'd like to include analysis regarding which subgroups of patients might have a larger difference in CTA measurement versus graft size. This could prompt investigation into the characteristics of patients for whom CTA is not as reliable as IVUS. Lastly, the study lacks long-term outcome data. To conclude, previous studies have indicated that aortic diameter measurements obtained by IVUS have been larger than the diameters obtained by CT. This study showed that patients who received IVUS in addition to CTA did not receive differently sized grafts compared to those who received CT alone. Despite the potential advantages of IVUS, patients in both groups in this study had similar rates of technical success in surgery and similar postoperative outcomes, strengthening the idea that CTA could be sufficient for endograft sizing following blunt thoracic aortic injury. The use of routine IVUS in BTAI patients may not be warranted for graft sizing, but further study is needed to determine if there is any subgroup of patients who may benefit from IVUS use. Thank you. I'll take any questions.
Just a quick question. The real issue is, did you change from the CT to the IVUS? So were you able to go back and say, based on the CT in the group that had IVUS, what was the size planned and what was the size planned after you used it, rather than comparing the two groups? Thanks.
Yeah, that's a great question and one we considered and wanted to look at. Unfortunately, the database didn't include the planning for the graft size based on the CTA measurement, so we had to sort of infer that if a patient had CTA and IVUS, that the final graft size used was based on one of those, but we couldn't necessarily determine which one, and so the lack of a difference between the two groups led us to think that it was probably based on CTA. Thank you.
Nice presentation. I actually have a more simplistic question than Linda's going to. How you actually make the measurements in an area of curvature that you'll see many times coming just to the left subclavian where a lot of your blunt trauma injuries occur. And with IVUS, you may be angulated there, and with CT, you may have some angulation. So we're using centerline flow measurements, and how do you account for areas of angulation with your IVUS measurements? Nice talk. Thank you.
Thank you. Yeah, it's definitely an important question. All the characteristics about how we're using IVUS are definitely important. Unfortunately, in this database, we didn't get that specific, the answer to that specific question. But going forward, trying to determine if IVUS is going to benefit any specific group of patients, answering that specific question is definitely important.
Hi, excellent presentation. Fernando Joglar from Puerto Rico. I have a question because I have seen in the patients we managed, we haven't seen a change in the aortic diameter, but we have seen a change in the iliac diameter. Did you guys look at the iliacs? Because that's where usually you see a change for these patients who they receive 1 liter, then they go get their studies, and you will see some vasoconstriction peripherally. Yeah. But I haven't seen that in the aorta. Did you guys look at that or have the capacity to look at that in that database?
We did not look at that, but I think in this database there is measurements relating to the iliac diameter. I specifically haven't looked at those or run any statistics on those, but it's certainly something to consider in the future. Yeah, thank you. Great point.
Thank you.
Thank you.
The next paper is State of the Art, a population-based study of trends in diagnosis, treatment, and mortality spanning 4 decades. will be presented by Dr. Sen from the Mayo Clinic, Rochester.
Good afternoon. We have no disclosures. Overall and gender-specific reduction in abdominal aortic aneurysm-related mortality with screening and endovascular therapy have been reported. However, the impact of these improvements at a population level have not been studied and was the aim of this study. We utilized the Rochester Epidemiology Project to identify all cases of AAA, confirm their residency, and then individually verified clinical diagnosis and all relevant data. We had 1,537 patients, majority were male, with a mean age of 74 years. The incidence fluctuated. There was a rapid increase, followed by a decrease to the pre-existent levels. Majority were male, and the incidence did increase linearly with age. There were 172 patients with rupture, and here there was a significant linear decline in incidence over the study period. The diagnosis of an aneurysm was made at presentation with rupture in a majority, 56% of this cohort, and 66% overall after 2007 satisfied the current Medicare screening criteria. Looking at the entire cohort, based on the mode of detection, patients with incidental presentation were more likely to be older, female, present with larger aneurysms, and progress more to rupture with similar rates of repair and mode of repair. In the entire cohort, only 23% of patients were detected on screening with no significant change per year and no significant change in demographics. Gender-based differences were significant. Patients who were female were likely older and less likely to undergo repair. Although they presented with smaller aneurysms at diagnosis, their overall progression to rupture was not different. Based on Kaplan-Meier analysis, at a median overall follow-up of 18 years, survival for those with aneurysms was 87%, 40%, and 22% at 1, 10, and 15 years respectively. That was significantly lower than population controls. The cumulative probability of aneurysm-related death at 10 years was 7.3%. Although the median age at diagnosis was higher in women, age-adjusted survival was similar to men. And on multivariable regression, older age, Charlson index more than 7, and incidental detection were the only significant factors for overall mortality, and this did not include the type or the urgency of repair. So in conclusion, the incidence of rupture AAAs and aortic mortality has decreased significantly in the population over time. Aneurysms are diagnosed and repaired in women almost a decade later than men with similar age-adjusted mortality. And with that, I'd like to thank the Society for the opportunity to present this work. Thank you.
Do you have any idea what percentage of the population gets screened?
Yes. We have noticed an increase in the screening numbers once the EMR-based guidelines were implemented. However, as we showed, it's not quite enough. Only overall in the first half of the study, it was around 18%, 23% in the middle, and 17% towards the end.
And am I to understand correctly that women are diagnosed with the aneurysm a decade later than men in age? But when they're diagnosed, it's not that they're being diagnosed with a larger aneurysm, they're being diagnosed with the same size as the men are being. So women develop their aneurysms later.
Yes, that's what we are seeing, and we have more data for that, which hopefully we'll share in future meetings.
Oh, okay. All right.
Thank you very much.
Thank you.
All right, next is preemptive IVUS and fusion-guided electrocautery-assisted aortic septotomy for endovascular repair of chronic aortoiliac dissecting aneurysms. not to be presented by to be presented by Dr. Timuron.
Yes, I'm presenting on behalf of my.
Yes.
Sorry, I'm presenting on behalf of my the first author and fellow at UT Southwestern, Ben Lee, who is home with his newborn.
Oh, congratulations.
So these are the disclosures. Some devices presented here are investigational. I want to acknowledge my dear friend Gustavo Odrich, who shared with me some of the illustrations presented here. The strategies for false lumen management include several, including the Knickerbocker technique, the candy block, laser atherectomy, and a modified stabilized technique with balloon inflation of the septum. However, most of these techniques do not result in complete false lumen exclusion. There is a novel technique that actually we became aware several years ago when it was presented at the 2019 Midwestern Vascular Society meeting by the group from Henry Ford, specifically Lloyd Cavani. Actually, this has been just published in the Journal of Vascular Surgery. What he describes is the use of the stator wire, which is fully coated with PTFE, and therefore isolates heat. It's advanced through an Avicross catheter. In the mid portion of the wire where that you will use to do the septotomy, you scraped the PTFE, and then you advance the wire into position. To do that, you either cross a primary fenestration or you create one yourself with a wire. This wire has a heavy tip, but sometimes you use the electrocautery. The idea is to activate the wire with the electrocautery, as you will see here. So once you go from true to false lumen, you advance the wire into the false lumen. We're using fusion guidance here. And then you snare the wire in the false lumen. Then you basically get true and true access with a wire going from false to true lumen. You connect the electrocautery to the back of the wire, which has to be scraped too. And then you do your septotomy, activating the electrocautery using the cutting mode, in this case up to 60. The idea is not to traction the wire, just let the wire do the cutting. And this is what you see after you do that. You basically create just one lumen by cutting the septum. Usually we start in the descending thoracic aorta. If we just do an TVAR, then we end there. But if we want to do a fenestrated TVAR, then we go all the way down to the iliacs if these are involved. So in our first 7 cases that were enrolled over the 12-month period, we've done more than 20 now. The mean age was 58 years. 4 were done for FEVARs with custom-made devices. 4 were for FEVAR with modified devices. 2 T-branches were used, and in 3 cases, a TVAR was performed. The technical success was 100%. These are images of how the lumen looked before and after at the level of the proximal landing zone or the aorta itself, and farther down. And this is how it looks in the iliacs. The idea is to create just one lumen so you can have complete expansion of your flared legs. The aortic diameter increased from 15 to 28.7, 71% increase in diameter in the aorta, and in the iliacs increased from 13.8 to 21.7, with a 125% luminal gain in diameter. All these were statistically significant. Same thing when you compare cross-sectional area, there were significant increases in the aorta and in the iliac, with significant luminal gains. So in conclusion, complete false lumen exclusion and thrombosis should be attained in most cases if feasible. Electrocautery-assisted aortic thermal septotomy shows promising results, and septotomy can be done in a safe manner and facilitates true lumen expansion with false lumen exclusion. Thank you.
Carlos, can you just give us some inclusion or exclusionary criteria for this? Is it all people with a dissection? Is it, or what when would you employ this?
Yeah, that's important. I have to say, if we're dealing with thoracoabdominal aneurysm, and what we're going to do as a fenestrated or a branch, we tend to do septotomy in most of those cases unless the true lumen is fully expanded, which is rare. Now, you're just going to land in the, just what you want to get is, landing in the thoracic aorta to complete the TVAR. Instead of doing candy plugs and all these other things to stabilize, which almost never works, we do this. We just do the cutting in the landing zone. Now, we've done actually 2-3 cases, I think, recently, just to create necks for EVARs when the neck is dissected, but it has a good size. So I think we do it selectively, I would say, but that means that we use it in the majority of patients.
Mark?
That's great talk there, Carlos, and great technique. Thanks for sharing it with us. Question is for when you need to do the septotomy through the visceral segment, have you had any issues with a flap closing off the origin to the vessels? Do you pre-cannulate in those cases? Would you ever septotomize through that visceral segment and then leave it?
I have to say I have not done that, but one of my partners and co-authors, Chairman Bake, he kind of worries more about some of those, and he has a pretty stented zone or access then, but I haven't seen a problem with that. What you really see here is when you cut, the septum retracts. You can see the edges burned, and usually it's chronic, so it's not that mobile. Now, retraction, I think, is important, and for that, that's why we tend to use a higher cutting power, like 60 or 70. In his paper, Cavani said that you can do it with 20 and 30, but the time I used less, I saw that it retracted less.
Thank you very much. I'm sorry we're out of time. So the next to final paper is degree of progressive dilation of external iliac artery after endovascular stent treatment by Dr. Martinez from Stony Brook.
Hi, good afternoon. My name is Camilo Martinez from Stony Brook. This is a proof of concept study as part of a bigger computer vision project that we're working on. Successful endovascular treatment of abdominal aortic aneurysms is highly dependent on a healthy proximal neck and distal iliac anatomy. Common iliac arteries, most likely as the distal landing zone, are susceptible to progressive degeneration and a compromised seal. Let's talk about external iliac arteries. So they, because of embryology, they are inherently resistant to degeneration. Iliac artery aneurysms occur at less than 10% in the internal, about 1% in the external, and 89% in the common. And this is a tweet I saw from Dr. Park. He described it as the Loch Ness monster of vascular surgery, an external iliac artery aneurysm. So although not specifically studied, it would seem as though choosing the external iliac as a distal landing zone would lead to less reinterventions given their inherent resistance to degeneration. So we aim to test this hypothesis that the EIA does not dilate over time in either native arteries or those stented for AAA interventions. The way that this was done was we took a group of control patients. So on the left was what we called the control patients bifurcated EVARs without limb extension, measuring the iliac arteries at different locations over 3 different time periods. And then on the right-hand side is what we call the experimental group, with either at the index procedure or reintervention, included limb extension, whether that was coils with external artery limb extension, Gore IBE, whatever the case was. This was all done using 3D reconstruction on TerraRecon. On the right-hand side, you can see some problems that I encountered with some of these measurements. So on the right-hand side, in an attempt to try to use some of these CTs with IV contrast, they're just unacceptable for the measuring. And then highly calcified vessels like the one on towards the right, you can see that it's hard to measure. Those are the automated TerraRecon, but of course we did these manually. So native EIAs do not dilate over time, as seen in the top left. This was done measuring the EIAs over time using repeated measures ANOVA. Stented versus non-stented, that on the right-hand side was also not significant. So this was using its own control, which is The stented limb versus the contralateral non-stented limb, which I believe is the best control anyone could ever have, showed no dilatation. And then stented CIA versus stented EIA did have a significant difference, where the CIA and these end of stent arteries did have progressive dilatation. Landing in the external does have its risks, of course. It's in the forefront of everybody's minds here, but it's been widely studied that there are ways to try to minimize buttock claudication, pelvic ischemia using plugs or coiling most proximally. External iliac artery extension also has its benefits, as shown on the top left paper, with increased sac regression. And most recently, a 5-year outcomes paper of GORE IBE was published. And it would be interesting to see if maybe in the future indications could be expanded. Limitations of this study include paucity of longitudinal data. So, of course, with TerraRecon measurements, I was only able to use CTAs. In our practice, a lot of the times we obtain duplex ultrasounds for follow-ups and inter-observer variability, and that's going to be minimized with a situation similar to the project here. This was presented at the Houston Aortic Symposium, where our biomedical engineering group was able to use flow measurements to be able to derive geometric analyses. And so if we kind of extrapolate this and start working towards the abdominal aorta and into the iliacs, we can identify patients that would be at highest risk for reinterventions and potentially offer them limb extension from the get-go. Thanks.
So what are you recommending?
Yeah, I know. I knew this question was going to come. No, I do not recommend prophylactic extension for every patient. I think it's going to be, with the technology that we're able to develop over time, we can start to identify those patients at highest risk, older patients, those that have reverse tapered iliacs, those that you would consider bell-bottom techniques. Potentially from the get-go, you may want to extend those from the beginning to decrease reinterventions.
Any questions from the floor? Thank you.
Thank you.
Thanks.
All right, the last paper for this afternoon session is Utility of 30-Day Computed Tomography Scan Following Elective Endovascular Aortic Aneurysm Repair by Dr. Budik and colleagues from University at Buffalo.
Hello, good afternoon. Thank you for the opportunity to present. The objective of our study was to evaluate the optimal timing of follow-up CT scan following EVAR. Our hypothesis was, in patients who meet IFU and have negative completion angiograms, initial follow-up CT scan can be delayed to 1 year. Current guidelines recommend first surveillance CT and color duplex ultrasound be performed at 1 month. If concerning findings are identified, a 6-month CT should be performed. If there are no concerning findings, yearly surveillance with color duplex ultrasound should be continued indefinitely. Guidelines do not address IFU compliance or completion angiogram findings. This was a 5-year retrospective review of all patients who underwent an elective EVAR. Patient demographics, operative details, and follow-up CT results were collected. Compliance with IFU and/or presence of any endoleak on completion angiogram was correlated with the need for reintervention within 1 year. A total of 138 elective EVARs were performed. 61% were fully compliant with IFU. The predominant type of implant was GORE. 45% of EVARs performed were fully compliant and had no evidence of endoleak on completion angiogram. 26.1 demonstrated endoleak on intraoperative completion angiogram. There were 3 type 1A endoleaks, and none were fully compliant with IFU. There were no type 1B, 3, or 4 endoleaks. 33 had type 2 endoleaks. CT scans were available for review in 91% of patients, with a 30-day CT available for 64% of patients. Reintervention prior to 1 year was never required for elective EVARs within IFU and negative completion angiogram. 2 patients required intervention prior to 12 months for new endoleaks seen on follow-up imaging. 1 had a type 1B endoleak intervened on at 2 months. 1 had a symptomatic type 2 endoleak that required reintervention at 5 months. Neither were IFU compliant. Reintervention was not required among EVAR completed within IFU without endoleak on completion imaging, while 2.9% of those who did not meet criteria required reintervention prior to 12 months post-procedure. There was 100% sensitivity and 45% specificity. There was a 100% negative predictive value in all patients who met criteria did not require reintervention within 12 months. The limitations of this study include that it is retrospective and data is dependent on reliability of identifying endoleak at completion angiogram. In conclusion, reintervention prior to 12 months was never required among EVARs performed within IFU and with negative completion angiograms. Using this criteria, initial surveillance could be safely delayed to 12 months in nearly half of EVARs. Current guidelines should be reserved for EVARs completed outside of IFU or with positive findings on completion angiogram. Thank you.
Dr. Dietzig.
Hi, very nice presentation. We have not performed a follow-up CAT scan in 20 years. We do all of our first follow-ups at 1 month with ultrasound and then follow them with ultrasound unless we see an endo leak of significance, and that has not occurred very often where we have to intervene prior to that time. So what do you think about, instead of 1 year doing a CAT scan, doing an initial duplex, which is much cheaper than a CAT scan, no radiation, no risk of renal failure, and then following them with ultrasound and not obtaining a CAT scan?
Of course. So, well, we didn't specifically look at ultrasound numbers. From the data, you could imply that you could defer any imaging until 1 year post-intervention. While ultrasounds aren't necessarily radiation to the patient or the risk of contrast, there is still a cost associated with, taking up time in the vascular lab and getting the study done.
Okay, I would agree with that. So, but what about doing an ultrasound at 1 year instead of obtaining a CAT scan? I think the advantage of doing the ultrasound initially is then you can really follow it along with ultrasound rather than wondering, had you done the ultrasound earlier, if it would show something else, or had you done a CAT scan, it would show something else.
I think deciding to do just the ultrasound at 1 year is something else that would need to be looked in, but that we can't really decide from the information we have from our study.
Guillermo Escobar, Emory. Philosophically, I love what you're saying. Less radiation, less cost. I love what you're saying. You have a great vascular lab. You don't need a CT. I've treated at least one rupture post-cleared ultrasound. So I think we have to put guidelines as far as, obese patient, perfect visibility, experience of text, et cetera, because ultrasounds are great, but they're not perfect for visibility. One piece of bowel gas is type 1A that we miss. Just saying.
Thank you.